Hello everyone. Now I'll discuss question of neurology. So we have a 56-year-old man and he's come to the emergency department an hour after acute onset of right-sided weakness and numbness. 56 years, an hour of the problem. And symptom progressed over a course of several minutes. That means progressive symptoms. And he is now experienced nausea and headache. Patient has never seen a physician for many years and take no medication. He smoked half packets of cigarette for 32 years, heavy smoker, long, and BP at the moment is 180, 110. Hypertension is there. And pulse normal. Physical examination revealed 3/5 muscle strength and hyperreflexia in right upper and lower limb. Sensation in pinprick and slight touches decrease on the right side. That means there is hemianesthesia and hemiparesis on the right side. Mild dysarthria is there. And ECG shows normal sinus rhythm. Left ventricular hypertrophy that indicate long-standing hypertension. He's non-diabetic. His lipid profile is normal. Non-contrast CT scan is shown below. Well, there's a bleeding. Bleeding is there. Most likely cause of the problem is what? Okay. Well, if you again go back to the CT scan, this is bleeding in the basal ganglia area. Okay. And if you review the history, he is a 56-year man, right hemiplaces, right hemianesthesia, and there is headache, and it is progressing over a period of minutes. Now, nausea, vomiting, headache also. That indicate the patient has right hemiparesis with raised ICP, and since the problem is increasing in due course of the time in minutes, it's more like a hemorrhage, and that has been confirmed by CT scan also, ganglia. Yeah. Well, the answer to this question is hypertensive vasculopathy. Remember, his BP is still very high. It's 180/110. He has left ventricular hypertrophy also. That indicate long-standing hypertension which is untreated, and he has not been to a physician. So we can think about hypertension vasculopathy. Now, hypertensive vasculopathy can lead to brain in certain areas. Classical thing. What are those areas where the bleeding occurs other than the cerebral parenchyma? Write down the answer, stop the video. Answer is most common location is basal ganglia, which is putamen. Like in this patient also, the bleeding is in the putamen. Cerebellar nuclei, thalamus, and pons. But now the question is, this gentleman has finding of right hemiplegia and right hemianesthesia are there. But this cannot be explained. Even I say the bleeding is occurring in the putamen. But putamen bleeding will not explain, cannot explain this thing. How can, and of course, we know it very well, these things can happen only the lesion occurs in the internal capsule. What is the suspense behind this? Stop the video, write down the answer. How can a patient with putamen bleed can have feature mimicking like internal capsule lesion? Stop the video. The answer to this question is patient has acute left-sided basal ganglia. Patient has the clinical finding on the right side. The patient has acute on the left basal ganglia. Now, first of all, the bleeding is hemorrhagic intraparenchymal. Sudden focal neurological deficit, like in this case also, problem started 1 hour ago. And gradually worsen over minute to hour. In this case also, it is gradually progressing, worsening minute to minute. So one thing is very clear that we are dealing with hemorrhage. In hemorrhage only, you also get feature of raised ICP. Like in this case, headache, nausea, vomiting. Later on, altered sensorium can be there. Now the question is, putamen hemorrhage almost always involve the adjacent internal capsule. How come? Look into this picture. Yeah, lovely picture. This is the putamen. Okay, this is a putamen. And here lies the internal capsule. So when the bleeding occurs in the putamen, the blood can very well go into the posterior limb of the internal capsule. So as such, putamen bleeding occurs in the putamen, and as such, bleeding does not occur in the internal capsule, but since they are lying in close approximation to each other, blood will go and involve the internal capsule, especially the posterior limb. In fact, this is the posterior limb, the anterior limb of internal capsule, anterior, posterior. Here lies the motor fiber and here lies the sensory fiber. So bleeding occurs like this, and it is involving the internal capsule. This is the putamen. This is the putamen. What is has been shown to you. Putamen, the bleeding will occur and will go like this, and this is how the clinical finding of internal capsule lesion are there. So ultimately, it lead to contralateral hemiplegia or hemiparesis, contralateral hemianesthesia, and this is due to disruption of corticospinal and somatosensory fiber in the posterior limb of internal capsule, as I explained to you in the picture also. So as the hemorrhage expand, raised ICP features come, which cause nausea, vomiting, and altered mental status. In this patient, nausea, vomiting, headache is occurring, but so far, raised ICP is not that much to lead to altered sensorium. Well, when we do it, we always get hyperdense or non-contrast CT scan like this, which is the location for putamen hemorrhage. Hypertensive vasculopathy involves the small penetrating branches of the major cerebral artery. Especially in this case, it is the middle cerebral artery. The most common cause of spontaneous deep, and this is the most common cause of deep intracerebral hemorrhage. Well, I told you they are now in this case in particular, branches of MC are involved. Name which small penetrating branch are involved. Name the arteries. Stop the video. Write down the answer. Well, arteries involved are medial and lateral striate branches of middle cerebral artery. Look into this picture. Look into this picture. Okay, this is the middle cerebral artery, and they are medial and lateral lenticulostriate arteries. Now, something very interesting to talk. They can rupture, and they will lead to bleeding, as I told you. But sometimes they can even go into ischemic also, that we call as lacunar stroke. But thing is, these are the branches, so medial and lateral lenticulostriate arteries, which can rupture, can bleeding, and they can have ischemia, which can lead to lacunar stroke. Look into this. Look into lovely picture. These are lenticulostriate arteries shown in this side. This is the middle cerebral artery, lenticulostriate artery, and this is the what you are talking about is the location where we are having this the area which is the putamen area typically, and it's a place where the bleeding will happen. Okay, so typically this side is the artery shown, and this is the area shown, nicely correlating with the artery and the area. Well, chronic hypertension lead to formation of Charcot-Bouchard aneurysm. They may rupture and bleed within the deep. So ultimately, this is the Charcot-Bouchard aneurysm which bleed as in this case also. But again, I have a question for you. Stop the video. What are these aneurysm? What are they? Stop the video, write down the answer in your copy. Well, they are minute aneurysm, microaneurysm in the brain that can occur in small penetrating blood vessel, as I mentioned, lenticulostriate artery. They have a diameter less than 300 microns. Less than 300 microns. Very, very important point. They are the most common involved in lenticulostriate branches of the middle cerebral arteries, as I told you, as I mentioned in the previous slide also. Look into this. This is the middle cerebral artery. They are the lenticulostriate branches, and these are the aneurysm getting made, and they are the lenticulosteroid artery. Lovely picture to explain to you. Look into this beautiful picture, and they are going into the putamen. Well, let's look into other option. Amyloid vasculopathy, it typically occurs in spontaneous lobar cortical hemorrhage. They don't lead to small bleeding. Occipital or parietal lobe, especially in the elderly people above 60 years. Our patient is a 56 year, quite near to that age. But the bleeding pattern is not in the putamen, it's the lobar. CT findings are not consistent with lobar cortical hemorrhage. AV malformation, brain, they are the most common cause of bleeding in the children. Our patient is a 56 year, and that doesn't fit into this. Okay. Carotid artery atherosclerosis, thrombosis, or embolism can lead to this problem. Well, in our patient, there are risk factors of hypertension and smoking are there. Okay, they are present there. But this ischemic stroke can undergo hemorrhagic transformation. Point to be noted very carefully. Patient come with the ischemia, later on hemorrhage occurs. It can get converted into hemorrhagic stroke. Now, embolic stroke are more likely to bleed than the thrombotic stroke. And typically they involve the cortical lobar segment. Multiple vascular distribution are there. Again, our CT findings are not consistent with this. It's not a lobar hemorrhage, it's a small so-called area, putamen bleeding is there. Cerebral venous thrombosis typically occurs in patients with hypercoagulable state, like contraceptive use, malignancy. They come with headache, altered mentorium, seizures, focal deficit. Diagnosis is confirmed by MRI of the brain with venography, as head CT shows may not show any abnormality. Very, very important point. Well, cerebral hemorrhage, venous thrombosis, it can happen anywhere. So now you can see cerebral venous thrombosis, lovely picture. First is the anatomy, and here is the MRI finding also. Cavernous sinus, lively suprasagittal, inferior sagittal sinus. Okay, this is straight sinus, and these are the finding shown by the cerebral venous angiography. And this is the lesion that is being shown. So golden line to remember: spontaneous deep intracerebral hemorrhage, typically caused by hypertensive vasculopathy involving penetrating branches of the major cerebral artery, especially the middle cerebral artery. Common locations are putamen. Most common site is putamen. Cerebellar nuclei, thalamus, pons. Putamen hemorrhage often produces contralateral hemiplegia and contralateral sensory loss due to involvement of adjacent internal capsule. Thank you very much.